Good afternoon, everyone. Welcome to our session, which is the UNPAUSE session, for us to learn, embrace, and thrive after we have been diagnosed and treated for breast cancer. And love, embrace, thrive are actually slogans for metastatic breast cancer to show that we need to unpause our lives, not to pause, but to go ahead and get our treatment done and to continue to live life as well, whether we have early breast cancer or metastatic breast cancer. I'm sure you recognize my voice. I'm Ranjit Kaur here, President of Breast Cancer Welfare Association, Malaysia. We bring to you many sessions of Unpause almost every weekend until December this year. And this program is supported by Pfizer Malaysia. So we are very thankful to Pfizer Malaysia. This is a joint project between Breast Cancer Welfare Station Malaysia and Pfizer. And today we'll have a 1-hour session. The speaker for today, who has been invited to speak, is Dr. Mastura Md Yusof. So Dr. Mastura will be speaking on treatment options in advanced breast cancer and metastatic breast cancer. She will also add in signs and symptoms to look out for after treatment. Dr. Mastura Md Yusof is a consultant clinical oncologist. She's a board member of the Breast Cancer Welfare Association Malaysia. She has very kindly agreed and accepted to speak in today's session. She will speak for about 40 minutes or so, and then we will have questions and answers. You can put your questions in the chat box, and we can then read out the questions for you. And without further ado, can you join me to welcome Dr. Mastura Md Yusof to give her session? Thank you, Dr. Mastura.
Thanks, Ranjit, for the kind introduction. So, we are here today, thankfully, is to discuss advanced breast cancer. So, we know that for breast cancer patients, we have early stage breast cancer. That means these are cancers that are diagnosed between stage 0, that's ductal carcinoma in situ, to stage 3C, means that stage 3 means that the patient's cancer may have gone to involve the lymph nodes. So there are a group of patients that we consider as advanced breast cancer. So these are patients whom their cancer either at diagnosis is already at stage 4, meaning that the cancer has actually spread to a distant organ, and then the cancer relapse in the future after they had a treatment, or a patient whom the cancer has not spread anywhere else, but it is locally advanced. That means that a curative surgery cannot be performed for the patient. So you can see from my slide, so we will start with the presentation, yeah? Okay. So this is the slide showing our National Cancer Registry report. This is basically showing the statistics of cancer in Malaysia. So this is the latest one that we have up to 2016. So for 5 years between 2012 to 2016, you can see on the right side, the orange color, right? You can see among females in Malaysia, 34% of the cancers are breast. Okay, so this is followed by colorectal and lung. So if you lump a few cases, a few cancer types in this chart, you could see that breast still is more than a few cancers combined. So breast cancer is very, very important. Okay, so why I put this up is to show you how many patients are going to be affected by breast cancer, and also that in Malaysia, besides it being common, patients that being diagnosed in advanced stage is also common compared to in the in the other parts of the world. Okay, so in order for us to understand advanced breast cancer, so we must know that cancers can spread. So breast cancers that develops within initially the breast tissue can actually invade to the surrounding area and then later spread through the lymphatics and the blood circulation. A tumor grows from a single cancer cell, then it invades the neighboring tissue, and then it spreads through the lymphatics and blood vessels to other parts of the body. Then you get the metastatic breast cancer. Next, please. Okay, so the lymphatic system and the blood circulation in the body is just very, very rich. Okay, it can just go anywhere and everywhere in our body because our body is just built as such, right? So the time taken to spread to the other parts of our body may take months or may take years. So it depends on how aggressive the cancer is. So that then we will discuss the type of cancer and the aggressiveness according to the type of the cancer. So meaning that aggressive cancer can metastasize quite rapidly, while the slow growing cancer can take years for it to metastasize. Next, please. Okay. So when you have been diagnosed with cancer, and we know that we do not want any of you all to actually face the cancer alone. Okay, so no patients have to actually face the cancer alone. That's the reason why we do this group with advanced breast cancer, with BCWA, and we have pharmaceutical company, healthcare professionals making effort to ensure that patients are not facing it alone. So next, please. So as much as we know that we do not want that, okay, but no one should also treat cancer alone. So what I mean by this is that breast cancer has to be managed, especially if it's advanced breast cancer, has to be managed by a team. It's a team of healthcare professionals, and they can be managed by multiple types of treatment. So I do not want any patient to think I have advanced breast cancer and therefore I have to be treated with chemotherapy, and I don't want chemotherapy and that's it, I'm not going to do anything. So it's not like that at all. So you have to be managed by a host of people and also of multiple types of therapy. So once a patient has been diagnosed with cancer, it is important that we tell the patient or we tell the family members that they must take time to discuss all the possible treatment and all the possible options available out there in order for us to come to the best treatment option for the patient. Next, please. Okay, so this is just to show, remember earlier in the opening statement, I told you what advanced breast cancer means, okay? So we can have a patient who have inoperable locally advanced breast cancer, means that the cancer has not spread anywhere else, but at the breast itself, at the regional area, the lymph nodes is just too locally advanced that you can't do a proper surgery for them, okay? And you can have a patient with metastatic breast cancer, either appearing upfront, the first diagnosis already metastatic, or they relapse in a few years later. Or you can have patients who has had treatment before and then they have a recurrent at the breast or at the axilla, but the cancer has not gone anywhere else distantly. So these are the patients whom we are going to consider as advanced breast cancer, and they are treated basically nearly the same way. Next, please. Okay, so this is an example, okay, example of what we meant by advanced breast cancer. Okay, so next please. Okay, this is also other example. So cancer occurring in the chest wall that is not amenable to surgery, or cancers occurring in the lymph nodes surrounding the area of the breast. So this could be a local recurrent. Okay, next please. Okay, so when we are discussing advanced breast cancer, for patients, they would say that they would want the best treatment. So most patients want us to actually give them the best treatment available to treat their cancer. But much of the best treatment for patients would depend on what is the type of cancer that the patient have, whether they have hormone positive type of cancer, whether they have HER2 positive type of cancer, or the cancer is the type called triple negative breast cancer. Okay, and of course, when we are treating advanced breast cancer, what is the aim of the cancer? So patient may say, doctor, I want the best treatment and can I have cure, please? So sometimes we are not able to cure patients with advanced breast cancer, and cure is also quite subjective actually. So we usually want to control the cancer the longest possible. So we want to control the cancer with a good treatment that will prolong their life and also alleviate suffering. Means that if the patient is suffering from the effects of having advanced breast cancer, for example, bone pain, or they have bleeding from their breast tumor, or they have breathlessness from lung metastasis. So we would like to improve on that symptoms by controlling the cancer, and then also improve the quality of life of the patient. So that would be our aim. And what would be the treatment choices, okay, that we have for the patient must consider what is the side effect of the treatment. So and also the patient's fitness to actually receive the therapy. So somebody may want everything there is, like a combination strategy with immunotherapy plus chemotherapy, but the patient's fitness to receive those therapy may be not so good. So the treatment choices will depend on this as well. Okay. What about patient's wishes? So patient's wishes means that what does the patient desire to have in terms of a good treatment, but at the same time, she or he may not want a certain side effect. So, for example, they say, I don't mind chemotherapy, but I would like to have a chemotherapy that does not cause me to have hair fall, or I want a chemotherapy that will not make my numbness from previous treatment with chemotherapy worse. So something like that we have to consider. The last is, of course, cost. So cost of therapy is often a bane to some patients, but sometimes we want to give them the best that we have, but the cost may be a limiting factor. Okay, next please. Okay, so these are the examples of treatment that we have to treat advanced breast cancer. So like I said, no patient should be treated with just one therapy alone. So sometimes in the evolution of their therapy, in the evolution of their cancer trajectory, they will be treated with multiple treatment. Okay, that may include surgery, even for radiotherapy, targeted therapy, and so on and so forth. Okay, next please. Okay, so I will discuss systemic therapies for advanced breast cancer. So when we say systemic therapy, that means therapy or drugs that can go all over the body to treat the cancer cells wherever they are. Okay, so systemic therapy may be chemotherapy, may be hormone or endocrine therapy. So hormones, although you actually take it orally, but it gets absorbed in your body and will be delivered by blood to all the cancer sites. Okay, other than that, you can also have injections such as goserelin or Faslodex or fulvestrant, and you can also have biological agents or targeted therapy that are also considered as systemic treatments. So they go everywhere in our body. And next will be immunotherapy, which is also given at the moment for breast cancer, is given via IV, intravenous, and that will be part of the systemic therapy to treat advanced breast cancer. Next, please. So chemotherapy, I think everyone knows about chemotherapy. So chemotherapy is used to treat all types of advanced breast cancer, either they are triple negative or HER2 positive or hormone positive. It can be used for any of these types of breast cancer. It can also come in either IV form or also oral form. You have heard of oral Xeloda or oral capecitabine or TS1. These are chemotherapy oral that we can also use to treat patients with advanced breast cancer. Next, please. Okay, so who are the patients among those who have advanced breast cancer? Either they present first time around already advanced breast cancer, or they come in later setting with advanced breast cancer. So who are the ones that we oncologists would likely treat with chemotherapy, regardless of their type of cancer? Those whom we think the cancer is a bit is very aggressive. So it's like we cannot we do not want to play with time, so we want to treat them as soon as we can. And usually cancers that are aggressive like this, chemotherapy would be the best option because it will control the cancer as soon as we can. So patients who have what we call visceral crisis, that means their organ is critical. Okay, their organ is critical, and if you don't do anything, then a major complication may occur. So patients like this, for example, a very inflamed breast tumor such as this, or in this PET scan, you could see the liver here. The liver is infiltrated with a huge volume of tumor. So the tumor may actually cause liver failure if we do not treat it as soon as we can. And in this patient, the bone metastasis here in the cervical spine has caused a fracture of the collapse fracture of the spine, causing the bone bits to compress on the spinal cord here. So if you do not do anything, then the patient will be paralyzed. Okay, so we also have patients who have very bad lungs, and we have to actually control so that at least they can breathe better. And patients who have very symptomatic brain metastasis. So these are the patients whom we are going to treat with chemotherapy as soon as we can. Okay, next please. Okay, so what about other patients who do not belong to that category? So those patients whom do not belong to that category, they have advanced breast cancer, but they are not so critical yet. They are quite okay, you know. So we have factors that we would consider before we give them therapy. What is the cancer factor, the type, volume load, whether it's relapse or is upfront metastatic breast cancer, what is the patient's menopausal status, whether they are post-menopause or pre-menopause, means they're young, what is the physical fitness of the patient, and organ function, personal wish, so on and so forth, and then whether they had any therapy before that, whether they have any residual therapy before that, and of course, whether they have access to the treatment. Okay, next please. Okay, so for those patients that do not have to be treated so rapidly with chemotherapy, then we would consider what we call precision medicine. Okay, precision medicine means that research has gone deeper into breast cancer, and they have a better understanding of the behavior of the breast cancer, what caused the cancer to grow, what caused the cancer to be resistant to previous tumor, or why the cancer relapsed, for example. Then from there, from the research, they identify what is the most important mutation, or what is the most important change in the character of the cell that leads to the cancer forming, that leads to the cancer formation or aggressiveness or metastasize. Okay, so this important cancer driving mutation now has become a target for doctors to actually deliver treatment targeting that particular problem. So when we can have a target as the sole cause, or as the one of the sole causes for the cancer to happen, then we can refine our treatment approaches. Means that we can give a treatment that targeting that thing, that target that is only available at that specific individual with cancer. So if I have two patients, A and B, one doesn't have a target, the other one, B, has a target, both have breast cancer. So I just use the anti-target B in the patient B. I don't have to use it in patient A. So we become more refined, more tailored, more personalized in our treatment. Next, please. So this precision medicine, okay, the easiest example that we can use is, for example, in patients with ER positive, PR positive. So the ER PR positive is the characteristic of the cancer that we can identify within the person's tumor. We test it in the person's tumor. So when we know that the patient has ER PR positive cancer, then we treat the patient with substances, with drugs that is targeting the ER/PR, which is responsible for the cancer to grow. Okay, so the other one that is also very easy and very important for us to know is the HER2 positive target. So HER2 is the molecule that is identified to be extra in number in patients with HER2 positive type cancer. So when we know that, then we give them drugs that is targeting the HER2, which is the culprit that causes the cancer to be aggressive, that causes the cancer to happen. So these are some of the examples how we target patients, and we can deliver precision medicine, although they have stage 4 cancer, and they actually can do well if we can treat the reason or cause why the cancer happened. Next, please. Okay, so this is an example. Okay, the chart shows you here for patients with advanced breast cancer. They may not have mastectomy, they may not have breast conserving surgery, for example, but most of them must have had a biopsy that confirmed that they have breast cancer, and that biopsy must now classify them into whether they are ER positive, whether they are ER positive and HER2 positive, or they are HER2 positive, ER negative, or they are triple negative type cancer. So if they have stage 4 triple negative type cancer, then the treatment for them will be chemotherapy. And nowadays we have chemotherapy plus immunotherapy. So if they are HER2 positive type cancer, then the treatment for them is the anti-HER2 here, which is taxane, trastuzumab, pertuzumab, okay, and TDM1, and also this is given in combination with chemotherapy, or maybe just the anti-HER2 alone together. Okay, so if they are means hormone positive, then they will be treated with drugs, with hormonotherapy, or such as tamoxifen, or they can be treated with a targeted therapy called CDK4/6 inhibitors such as palbociclib, ribociclib, or abemaciclib. There are also other targeted therapy that we can use in patients with hormone receptor positive type cancer. Okay, next please. Majority of patients are belonging to this group, probably 50 to 60% of patients belonging to this group. Okay, so in this patient, there are many options available to treat them that is either as effective as chemotherapy or probably better than chemotherapy. So these options are like endocrine therapy, means that hormonal therapy alone, tablets tablets such as aromatase inhibitor or injection to the buttock with fulvestrant, and they can also have these hormones given together with a biological agent or targeted therapy, which are also oral. These are the CDK4/6 inhibitors, palbociclib, ribociclib, and abemaciclib. Okay, they also have another targeted therapy, which is an mTOR inhibitor called everolimus. Don't worry about this wording, but all you need to know is that this endocrine therapy can be combined with another targeted therapy that is very effective to treat the cancer, and these are oral therapy. They can also be treated with chemotherapy alone or chemotherapy in combination with other agents. And also for Malaysian public, you should know that there are also clinical trials being conducted in many centers in Malaysia with new therapies for patients with breast cancer. So you can try to find out if there are any, if you need one. Okay, and sometimes when patients have had one type of therapy for their cancer, and then the cancer, after some period of time that the cancer is controlled and the cancer gets progresses, then this what we call failure or progression. So after a failure to one hormonal therapy, they are able to actually go to other type of therapy. For example, for patients who have had one line of hormonal therapy, after that they can have oral alpelisib, which is another targeted therapy, or oral everolimus. Okay, and next please. So estrogen, so to understand why these therapies are effective or are efficacious in treating breast cancer, so you could see this cartoon here. You could see that there's a picture of the ovaries producing the estrogen, which is E, the green color one. Okay, so in premenopausal patient, the young patient with breast cancer, the estrogen is produced by the ovaries. Okay, so the estrogen will be delivered to the breast, and if there are cancer cells there that are estrogen dependent, then the estrogen will promote the cancer to grow. So for patients who are postmenopausal, these are elderly or those who are postmenopausal, the estrogen do not come from the ovaries, but the estrogen comes from the fat, from the adrenal gland, from the liver, because there's a conversion of the fat into estrogen that happens in these postmenopausal women. And so the same thing, the estrogen will go to the hormone-dependent cancer cells in the breast and leads to the cancer cell growing. So next please. So the principle of hormonal therapy is you just block the cancer from getting the estrogen. So you use multiple ways of blocking the cancer from getting the estrogen. For example, you use the leucine, you use aromatase inhibitor, you use tamoxifen. Okay, multiple ways of doing that. Okay, so this next please. So the endocrine therapy has been the preferred choice for people who with hormone receptor positive disease, even though they have liver metastases, even though they have lung metastases, even though they have multiple sites of cancer involvement in their body. If they are suitable to receive therapy, then endocrine therapy, means hormonal therapy, is our choice, our first choice to treat them. Okay, so this is in the recommended guidelines for many bodies that govern cancer treatment. So when they fail one therapy, for example, they have received one, next please, when they have received one endocrine therapy and they were found to be responsive to the endocrine therapy, the next, if let's say after a period of 6 months, 1 year, 2 years, their cancer progress, then they must be treated with another line of endocrine therapy. So unless they are found not suitable, then only we go to chemotherapy. Okay. Next, would be targeted therapy. So remember when I said precision medicine, one of the precision medicine that we know is what we call targeted therapy. So these are drugs that block the growth and spread of cancer by interfering with the molecules, the target that is involved in cancer growth and progression. So these targets are basically either molecules or maybe mutation that happen in the cell. So there are various targets, and sometimes you can target one target, but there are many targets within the cancer that you have to target lah, basically. So what I'm trying to say is that in the cancer cell you have many targets that leads to the cancer growth. So there are many processes that occur within the cell. So when you give one type of targeted therapy, sometimes the cancer may become resistant to the treatment. So my patients ask me, I have taken the anti-HER2 therapy, yet my cancer after 2 years progress. But this is something that we sometimes normally see because there are many targets for us to target, and sometimes after they develop resistance after we give them one therapy. So you need to move on to next target or try other drugs, right? Next, please. Okay, so HER2 positive, so just now we discussed ER positive, HER2 negative. So HER2 positive is another type of breast cancer that we all know. And this happened in about 20% of our breast cancer patients, okay? So they overexpress, means that the cancer have extra number of HER2, and because of that, the cancer is aggressive and leads to the cancer metastasizing, okay? Next, please. So this HER2 identification of HER2 in advanced breast cancer has led to researchers developing various types of anti-HER2 drugs that has led to tremendous success in treating cancer. Okay, so you could see here from just chemotherapy alone to having chemotherapy plus trastuzumab, which is an anti-HER2, followed by chemotherapy for and trastuzumab and pertuzumab, which is double anti-HER2, that leads to increment in the patient's survival period. So we have improvement in basically patients with stage 4 breast cancer whom we identify to have HER2 positive type cancer, and we treat them with the correct treatment, and then they are able to live longer. Okay, next please. Okay, so another beauty that arising from this precision medicine or treating patients with innovative drugs is that when we are targeting something that is just occurring within the cancer, then we are able to spare our normal tissues from getting the side effect of the treatment. So usually when treating patient targeted therapy, the side effects from the treatment is reduced. So the ones that we have, such as fatigue, cough, or rash, or decreased appetite, or constipation, these are side effects that are not really life-threatening and is usually quite manageable, and we can give you medication to actually manage these side effects. Okay, so next will be immunotherapy. So I know there's a lot of excitement and questions and excitement lah, basically, in patients when they want to ask about immunotherapy. So everyone now wants to have immunotherapy. So immunotherapy, next please. Okay, so immunotherapy is basically a treatment using our immune system, modulating our immune system to protect us from cancer cells. So you can see from the cartoon here, you can see that the immune cells are there, our own immune system are there to actually protect us from cancer cells. So they are supposed to kill the cancer cells from harming our body. But sometimes after a cancer has been formed, the cancer cells may have some ability or some characteristic that will cause the immune system not to kill them or not to recognize them, or the immune system is basically sleeping and not doing its job. So we need immunotherapy, which are drugs that can help to wake up our immune system and then attack the cancer cells, because that's what we want. Next please. Okay, so this is a cartoon to show you how tumors escape from the immune system. Okay, so this is a T cell mediated immune response that is you could see from here. So you can see the red thing is the tumor cell, the green thing is our immune system, the T cell. So it has a molecule called PD-1 that is supposed to actually give an immune response, meaning killing the cancer cell. But what happens is sometimes the cancer cell, they don't die. They don't die because they produce another molecule. They produce a character that causes it to not being seen by our immune system. Okay, so our immune system is basically looking like sleeping there. So we need to give the immune system a boost, so that a boost with immunotherapy, so that it will start to do its work to kill the cancer cells. So how do we know whether a patient's tumor is actually suitable or not to give immunotherapy? Is we can test the presence of the molecule within your tumor. So if you have the molecule within your tumor, then yes, you can be treated with the immunotherapy. Okay, so these are how the immunotherapy work. Basically, you give the drugs, and then the drugs causes the molecules to be activated again, and then you can kill the immune system. Okay, next please. So these are the drugs that we have used in breast cancer. So the drugs that are currently we are using is atezolizumab and also pembrolizumab for patients with triple negative breast cancer. Okay, so the last and not least is actually the presence of BRCA mutation in certain women with advanced breast cancer, and also having hereditary type of cancer, which we call the BRCA mutated breast cancer. So this happened in fortunately in not many people, just probably about 5 to 10% of breast cancers, and usually the breast cancer type that may have hereditary BRCA mutation is the triple negative breast cancer type. Okay, so in this breast cancer type, we identified that the cancer happened because of the inability of the cell to repair any DNA damage. So because of that, there are drugs that we can use to treat this condition, not the BRCA mutation, but BRCA mutation related breast cancer. There are drugs that we can use which are oral, and we already have it in Malaysia. So these are among the treatment that we can use to treat cancers. Okay, next please. All right. Okay, so I'm done with that. So I will probably take questions from here. Okay.
Thank you, Dr. Mastura. I think we can go to the questions. Is it possible for you to just give a brief about signs and symptoms to look out for after treatment?
So first thing first is breast cancer relapse may occur in 3 spots. One is actually at the breast itself. The second spot is actually within the lymph nodes surrounding the breast. And the third one is actually the other parts other than what we just mentioned. So in the breast itself, the signs and symptoms, of course, another lump or the changes in the breast, or skin nodules, or maybe if it's the chest wall, it's skin nodules, basically like redness, red nodules that you see on the skin. And then nipple discharge if they still have their nipple, so that will be in the breast or in the chest wall. Next will be the lymph nodes in the axilla or lymph nodes in the collarbone, in the supraclavicular area here. So you could have a lymph nodes occurring here, or maybe in the neck. Okay. Okay, then the third part, the third type of recurrence is actually distant recurrence. So distant recurrence will depend on where the recurrence is, which organ the recurrence is. So let's go from top to bottom. So what happen if there is a recurrence in the brain? So brain, you will have headache, you will have blurring of vision, you may, for example, or maybe there is poor balance, or maybe there's seizure. So that one will be brain. So going downwards will be probably neck, will be probably lymph node in the cervical region. So you get masses, lumps in the neck. And going downwards to the lungs. Okay, the lungs, cough, prolonged cough, hemoptysis means that you produce blood in your phlegm. And then breathlessness, feeling more tired, can climb stairs and tired, or unable to sleep flat because of water in the lungs, so they have to sleep upright. Then going downwards after the lung will be the liver. The liver is actually quite difficult to get some signs early on, because usually by the time they feel bloatedness or their jaundice, it's actually quite late. So other maybe early symptoms, maybe like feeling like wind, like gastric, like that. It's actually the liver that is enlarging. Bones must be bone pain, so you could have a persistent pain, the persistent pain that is increasing in severity. Usually is the same spot. So for example, if you have a shoulder pain that is, it's not the usual pain that you have for frozen shoulder, the usual pain that you have after having more activity than usual. So the pain is actually sharp and is due to, usually associated with certain movement, and it doesn't get better with the usual rest or painkillers. Did I miss any other organ? I think the rest are probably rare. The other organs are probably rare. So usually the relapse happen in the bones, in the viscera, which is organ such as liver, lungs, and then brain, and then the lymph nodes. Is that okay?
Oh, great, Dr. Mastura. I think that's fantastic. She said that, Dr. Mastura, with brain metastasis, is it better off to treat with gamma knife therapy compared to resection or radiotherapy? Also, is pertuzumab, can it cross blood-brain barrier better to compared to trastuzumab? So single target therapy agent is enough.
Okay. So the decision to treat brain metastasis with whatever modality, depends on a few factors. So if the patient has solitary brain metastasis, means just one brain metastasis, and that brain metastasis is causing mayhem. So the brain metastasis is causing compression on an important area in brain, and therefore perhaps waiting for radiotherapy to take place. I mean, gamma knife is radiotherapy. So waiting for the gamma knife to control the area may not be a good option. Then for me, at that time point, surgery will be what I would consider, provided that the patient is fit to have the surgery. Okay, patient has control disease below the brain. I mean, that like she's good. This brain mets is actually the only problem. Okay, for patients who have multiple brain metastases, maybe in separate areas in the brain, probably three brain metastases. They are small. Then they may not be able to actually have surgery, because you cannot be resecting 3 or 5 spots in your brain. So therefore, you have to think of other choice, such as gamma knives, or maybe you can do a stereotactic radiotherapy, for example, or you can do a cyber knife. So so there are multiple ways to treat brain metastasis, not just gamma knife. Okay, so this can be discussed with the oncologist that is seeing you. Okay, which is actually better. So for the question whether pertuzumab crosses the blood-brain barrier, so in patients with HER2 positive type of breast cancer, for those who do not know, they can be treated with trastuzumab and also pertuzumab, which are both anti-HER2 targeted therapy. So if a patient has brain metastases and they have had either surgery or they have had either radiotherapy to the brain, then there's a theory that says that probably the blood-brain barrier has been broken because of the surgery or because of the radiotherapy. So when we give the patient treatment with chemotherapy or pertuzumab or trastuzumab, then maybe the drug crosses the blood-brain barrier. What is important for us to know and to see is actually we have to test to see whether the cancer in the brain is responding or not, because if that's what we should do. I mean, we should have given the patient the treatment and we assume by the theory that it will cross the blood-brain barrier. After 3 months of giving the treatment, we should reassess the part of the brain and see whether it's shrinking. So whether if it's shrinking, then it's probably the effect of both the radiotherapy and the drug. So my answer to that would be possibly and potentially and probably largely yes, after you have given the patient either surgery or maybe radiotherapy to the brain. Okay, so can I go to the next question?
Yeah.
Okay, so I have stage 4 breast cancer, but there is no trace in my breast. It was found in my lymph nodes and spleen. It was puzzling to my doctors. I recently have been in touch with one lady who also has cancer in the lymph nodes and none in the breast. Okay, what is your take in this? And one common factor is we have both tried IVF before. Okay, so you explaining here is what we call occult primary. Occult means that we cannot identify the primary in the breast. But when we take out the lymph nodes and when we take out maybe areas in the body that has a tumor and we test the tissue for breast cancer profile, it turned out to be a breast cancer that has metastasized to that tissue. But when we assess the breast, we do mammogram, we do ultrasound, and maybe MRI of the breast, not able to actually find it in the breast. So this occult primary it does happen, although it's actually rare, but it does happen to some patients. I have had patients whom I have this occult primary, but we treat them with the treatment for breast cancer, and if they do well, they do well. So depending on their stage, of course. So that's called occult primary. Okay. Whether it's associated with both of you trying in vitro fertilization or IVF before, I'm not sure, because I have had patients who have tried IVF and they get diagnosed with breast cancer and the breast cancer is found in their breast. So I think it's probably purely coincident. Okay. With both of you having ER positive, PR negative, and HER2 positive, that's also something I would say just coincident, because we have other patients that have different type of cancers, irrespective of whether they do IVF or not. Okay.
Thank you, Dr. Mastura. There is another question.
Okay. So stage 4 metastasized to bones and liver. V is what? With HER2 positive during treatment, still have some bone pain. Does it mean the cancer cells are still there? Okay. So you have stage 4 breast cancer, which has metastasized to the bones and the liver, and you have HER2 positive type cancer, and during treatment you have bone pain. So I'm not sure whether the cancer cells are still there or not, because you need to look at whether you have had any evaluation or not. So evaluation means that you do scan, PET scan, bone scan, scans basically to see whether your cancer cells, your cancer are still at the bones or not. So often when we have bone metastasis, the structure of the bones have changed because some of the bone tissue has been replaced by the cancer. So even if the cancer has died, sometimes our body does not replace the bony tissue that has been eaten by the cancer. So you may still have some residual pain, although the cancer is no longer there, because the structures have changed. So you could have treatment with analgesics or painkillers. You could also have treatment with the bone modifying agent, such as Zometa or Xgeva, to help you with the bone pain. Also, of course, you need to know whether your treatment is actually working or not by having the scans, the evaluation of your cancer response. Okay.
So
another question.
We don't have any on the chat box, but if anybody wants to ask, jika nak tanya dalam bahasa Malaysia pun boleh, bahasa Cina pun boleh. We will get somebody to translate daripada bahasa Cina. So please feel free. We have still got a few more minutes. Dr. Mastura is an expert in this field, and do take advantage of this situation to ask questions to improve your knowledge in this area as well, so that we can take good care of ourselves. Anybody?
Are there anyone taking the CDK4/6 inhibitor? The palbociclib, the ribociclib, anyone taking? Here, the one.
Anybody on CDK4/6?
Because we are launching today.
What are you launching? Say again.
So for patients who have hormone positive type cancer, today after this at 4 o'clock, I'm going to share the launch for the latest oral drug for patients who have failed the hormonotherapy in the first line. So in the second line setting, those patients with hormone positive HER2 negative type cancer who has another mutation called PIK3CA, then they can actually take this tablet called we have it in Asia already.
Oh, great.
I cannot remember what is the trade name, probably Trazilian or something like that. But alpelisib is it's a new type of targeted therapy lah. Okay, so let's go to Elaine. Yep. Okay. Hi doctor, I'm a stage 3 breast cancer, done surgery, chemo, and still on Herceptin. How do I know my cancer is clear? Okay, what are the symptoms to know the cancer will spread to other areas? I think the symptoms to know whether the cancer has spread to the other areas we discussed earlier. And how to know whether your cancer is clear or not, then that is if you have stage 3 breast cancer, okay, we usually means that in the recommended guideline, it is asked that patients who have stage 3 or patients who have stage 3 HER2 positive cancer, what we consider as high risk, it is recommended for them to do a scan, maybe a CT scan, thorax, abdomen, pelvis, or a PET scan after a year from diagnosis, and every year subsequently up to 3 years. That means that if you are going to finish your Herceptin soon, if you finish your Herceptin soon, that means you're already a year from your diagnosis. So you can ask your oncologist about doing a scan lah, maybe a CT scan or a PET scan. Then if the CT scan or a PET scan shows no evidence of tumor, then you are considered to be in remission, 1 year remission. So you should then go on to take care of yourself, you know, take healthy diet, exercise, and then do another scan, so subsequent year and then the subsequent year for 3 years. That's how you know. Okay, how can diet and supplement can help control relapse? Okay, diet for relapse, if you look at studies done for breast cancer patients who are on follow-up following their initial breast cancer treatment, diet that is low in calorie, or diet that is what we consider as healthy diet lah, the suku-suku separuh, that is more veggie, more fruits, less calorie, less fattening stuff. These are the diets that you should take on your follow-up period so that you can delay or avoid relapse. Okay, so you should reduce your intake of any of those, you know, highly processed food or food that are basically unhealthy, like easy to say. You should avoid alcohol if you can, okay, in order for you to help control relapse. And you must exercise. So sometimes you all take a healthy diet, but exercise is also important. Keep yourself physically active. If you don't have any time to exercise, then try to do something that makes you physically active. It means that you probably walk more, or you park somewhere far so that you can walk, or you walk fast, so you do stuff such as that in order to get physically active. So these are the things that you could do. In terms of supplements, so far there has not been any data to show any supplement can help to control relapse. So you know, unfortunately there have not been any, not vitamins, not calcium, not spirulina or B17 or habatus sauda. So no supplements has been shown in any large trials or any large prospective observation study, for example, to show that it can actually reduce relapse. So just normal diet, normal healthy diet and exercise is good enough. Okay.
Dr. Mastura, I would like to add here with regards to exercise. We will be having Professor Nahar, Associate Professor Dr. Nahar, who will want to conduct a session on how to do movements and activities while you're sitting and watching TV or while you're standing. But we want all of you on 12th of December to dress up in your track pants so you can at the same time do the exercise while he's showing it to you. Yeah, and we will also have a session by the dietitian not very long from now. So keep a lookout for these sessions because you will benefit from it. Over to you, Dr. Mas.
Okay, so the next question is it necessary to do a genetic testing if it is HER2 positive? Okay, so genetic testing is not for everyone. So please remember that, okay? So genetic testing is only for a select group of patients, regardless of what is their subtype cancer, but more so, of course, for patients with triple-negative breast cancer or for people who have ER positive, HER2 negative. But they have to have other factors that we would advise them to do a genetic testing. So it's not for everyone. So it's actually quite long for me to say what these factors are, but you can look it up if you want. You can look up for what are the
Criteria.
factor, yeah, the criteria lah, in order for any patients with cancer to have a genetic testing. Okay, is full blood and marker test every 6 months essential for advanced breast cancer? I would say, if you're talking about advanced breast cancer here, so some of the patients who for some reason their cancer expresses some tumor markers, okay, so there are patients whom their cancer express CA or CA125. So if their oncologist finds that these tumor markers are high and this has been expressed by their cancers, and they can use it as a tool to see whether the treatment that the oncologist is giving is working, okay, by monitoring the tumor marker, then yes, maybe the oncologist would actually do the tumor marker test. But if you're talking about early stage breast cancer, those who have been treated for stage 2 breast cancer and then now on follow-up, if you ask me, it is not essential because there is no tumor marker test that has been recommended in the guideline to be robust enough for us to use to detect relapse, or you know, for us to use in order for us to detect relapse early. So in early breast cancer, no. In advanced breast cancer, in some patients who express it, perhaps yes. But this is very individual depending on the oncologist who are treating you, decision by them. Okay. Full blood also for early breast cancer also not that necessary actually. The mammogram and the ultrasound, yes. Okay, hi doctor. For patients taking letrozole, what are the chances of relapse? Okay, so it's really a broad question. So it's hard for me to actually answer just that for patients taking letrozole, what are the chances of relapse? So the chances of relapse is not related to taking letrozole or taking tamoxifen or taking letrozole and tamoxifen. The chances of relapse is relying on what is the patient's stage at at first diagnosis. So if your patient has stage 3, of course the chance of relapse is more than people who have stage 1. Other than stage is how many lymph nodes are involved. So you could have a patient with 12 lymph nodes or 15 lymph nodes and they are stage 3, and then you can also have a patient who have a very huge tumor that is invading the skin and they are also stage 3. But the person who have a lot of lymph nodes is the one that will be higher chance of relapse. Okay, other than this, the type of cancer. So the patients who have triple negative type of breast cancer or the patients who have HER2 positive, ER negative type of breast cancer, they are more likely to have a relapse, okay, more likely to have relapse. Other than that is whether they actually had treatment or not, or whether they completed their treatment or not. So these are the factors that lead to chances of relapse. So not really what kind of drug that they take. Okay, so cancer patients. Okay, next would be.
Yes, cancer patients.
So cancer patients are given a lot of instructions with regards to diet and products. Example, skincare, hair care, etc. It's quite mind-boggling. For ER positive and HER2 positive, are we supposed to avoid foods and products that example, what about external products? Most skincare have chemicals or herbs. Okay, very good question. Okay, so the instruction with regards to diet and products, okay, mind you, is not given by the medical team, I think. Okay, so that I will call it instructions because these are usually advice given by family members, by friends, by the internet. So cancer patients are just like other normal women. They do not have to, you know, really like avoid skincare or avoid deodorant or you know, all this topic, or do not go for hair dyeing or something like that. Just like normal, okay. But for consumption of products, consumption means that you take it in and it's carried by blood and your body has to process it. So when you are taking something that we and you are both not sure what is the content. So it may say, okay, this is a collagen, this is a something like, I also not so good at all this product jargon, but any of these things that they say it is that, we are not able to be certain, is it just that, or is there any other thing that they actually added? And any other thing can be medication such as steroids. It can be some substances that may be harmful when you use it in a long period of time, irrespective of whether you are ER positive, whether you are HER2 positive, you are triple negative. Any woman that take unknown supplement that may contain harmful substances in the long run will induce problem in them. If they don't get a relapse, they will get something else, some other thing. Okay, so I would not advise patients, doesn't matter their stage 4, doesn't matter their stage 1, the ER positive, HER2 negative, to take unknown supplements. I'm actually against supplements now. So supplements such as there are supplements that are okay, like calcium tablet, like maybe vitamins, like vitamin C, they're okay. But other supplements, product that they sell via MLM and all that, that one I'm not sure, because I'm not sure about its safety. I'm not sure whether it is harmful to us, okay, including herbs. And including Chinese medicine, you know, like ginseng and all that, because I'm not sure what it is. Okay, what are your comments on circulating tumor cells test? Okay, circulating tumor cells tests are tests that tries to detect cancer relapse as early as possible. So these circulating tumor cells have been investigated in many cancers, not colon cancer, lung cancer. So people try to see whether if they take blood or they take some of your body fluids, and if you can identify the DNA of a cancer cell, then you can identify that the patient is going to have a relapse or is relapsing, but it's still early on. But at the moment, in our clinic setting, means that our day-to-day practice, this circulating tumor cells has not been approved for use in our day-to-day setting for breast cancer. So that's why we are not using it yet. Okay, when we say there has not been any studies that can confirm, that can reassure us that doing this will lead to patient survival improvement. We can detect early and leads to survival improvement, and we are talking about mass, means the people in general. Okay, people in general. So it has to be conducted in a lot of patients, and then be shown to be effective lah in detecting the cancer early, and then leads to survival advantage for the patient. So because of that, we are not using it yet, but maybe in the future, if the data is stronger and there is more larger data to show that it is effective, then of course we would adopt it. Okay, but at the moment we are not adopting it. Okay, so why is cancer patient after mosquito bite, the skin has a red mark, doesn't go away? Okay, I don't think that is for everyone. So I don't think that's also for only cancer patients. So that's probably something individual. Maybe the person has allergic eczema, or atopy. So the person may be sensitive to the bite and it doesn't go away. So I can't say that for cancer patients lah. That is.
Okay. Thanks. Thank you. I don't think we have any more questions, Dr. Mastura. Would you like to, can take folic acid to increase red blood cells? Is there a deficiency in red blood cells? I mean, I think people are taking certain supplements without realizing whether they have a deficiency or they really need to take it or not. How do people make decisions about taking certain vitamins or supplements? Is it just feeling that I should take it?
So for patients who are on treatment, means that they are having their chemotherapy or they're having their CDK4/6 inhibitors, right? So they are going to have regular blood tests, and this regular blood test will tell us whether they have low hemoglobin or not. So these patients, the doctors will advise them to take the folic acid and ferrous sulfate to increase their red blood cell count. So if that is so, then please do so lah. Please take the folic acid to increase the red blood cell count. Okay, but if let's say you are on follow up and you are quite well, you are taking food like normal and all that, then maybe you don't have to actually take the folic acid to increase the rate. So the taking the supplement has to have a reason, means that has to have a reason lah. So if say that I'm let's say I'm your patient who still I from my menses, and I was treated with for my breast cancer about 2 or 3 years ago. So I'm follow up. So I'm menstruating. So therefore every month I lose blood. So when I take my food, I get dengue one time. Then the full blood count says that my hemoglobin is 11. But I am fine. I mean, with that 11, I don't have any symptoms. I don't have faintness. I don't have like this, tiredness or dizziness. Then perhaps I don't have to do anything about that, because 11 could be my normal red blood cell count. Okay, so if let's say if we are talking about another patient, if let's say another patient that is having a red blood cell count of 11 and is going to have the subsequent 6 months is going to have a treatment with chemotherapy, for example, then of course we would like to improve on the 11, because we know that with each treatment that the patient has, the hemoglobin is going to drop further. So we start the patient early by saying, look, you are going to have this 6 months of treatment. Your hemoglobin from 11 may drop to 9, like that. So let's start you with the folic acid right now, so that the drop will not be so bad. So something like that. So it has to be individualized to the patient's treatment, and what is the temp. I mean the timing of introducing such a treatment now. Okay, so is it advisable to see a dietitian to guide cancer patient? Yes, it is often, like I said, no patient should be treated by a lone practitioner. So a good cancer treatment involves many other healthcare professionals. So a psychologist, a dietitian, um, a physiotherapy. So we should have a multidisciplinary kind of care to treat the cancer patients, and advise the patient accordingly. So if let's say a patient with advanced stage breast cancer that is going to get treatment, so it's good for them to see a dietitian to guide them, because sometimes they have other diseases, such as they have diabetes, they have hypertension, they're taking drugs for gastritis, and they're going to have a treatment with ABC. So it's good for them to actually be guided by a dietitian. But the dietitian has to also be a dietitian that is familiar, that is working with cancer patients, not a dietitian that has no experience managing cancer treatment or cancer treatment side effects, so that they would know what to advise our patients. Okay.
Hi everyone. Now
Hi.
my husband had multiple myeloma. He passed on 8 years ago, and I'm having metastatic cancer. So I have 4 children. I'm worried for them. What should I do? How should I test them? Do they need to go for testing, for checkups? They are between 22 to 29. I got 4 children, 2 girls, 2 boys. Thank you.
May I know your type of cancer? Is it
HER2 positive,
okay?
and 1 minute, ER positive.
Okay, so you have triple positive breast cancer. Okay, so unless you have been diagnosed with a hereditary condition to cause the cancer, then you do not have to do anything extra. What you can do is you must advise them to practice healthy lifestyle, to be physically active, to eat good stuff, and to avoid alcohol or tobacco. Okay. Second is they can go on what we call early screening. So for if they are ladies, then they can start doing breast self examination if they are above 21. So they can do breast self examination already. So how to learn how to do the breast self examination is you Google it. Just Google it and learn how to do the breast self examination. So once, if let's say any of those who have reached about 30 years old, I would say, because you have breast cancer, you're probably about 50 plus.
Yeah, I'm 58.
Okay. So once your daughter reaches about 30 years old, like that, she must have done the breast self examination anyway before that. So when she reached 30 years old, then she can actually see a breast surgeon and get the breast surgeon to do like a regular kind of ultrasound of the breast, and just follow up like that until they reach 40, and then she can do a mammogram. Okay, so that one is for the girls. And then healthy lifestyle, screening, okay, breast examination and also screening, and the third thing is vaccines. Okay, so because you ask us what you can do, right? So for those who are already sexually active, they can take the HPV vaccine, okay, to reduce their risk for cancers, because we cannot be thinking just breast cancer here. We have to think any type of cancers. Then for those who have reached about 40 years old, they can do stool examination for colorectal cancer. And then the other thing that we can screen for is actually lung cancer, but that is when they are quite older, like 45 to 50, like that. Then it's actually a CT scan. So that's like really like 20 years down the line. Maybe at that time there are different type of screening tests to be done. I'm not sure. Okay, but these are what I advise you to do.
Thank you, Dr. Mastura.
Sorry.
Thank you, Dr. Mastura. So we have next week, Saturday, on letting go after you surviving breast cancer, continuing to live life, how to learn to let go. That's what Associate Professor Dr. Tan Seng Beng will be talking about. And we will have the role of traditional and complementary medicine in breast cancer, also by Dr. Theo from IKN. So do join us next week. On your speaker, we want to see all of you, so you can clap your hands to thank Dr. Mastura. Come on, let's see your faces. Let's clap.
Thank you.
Thank you, Ranjit.
Thank you, Ranjit.
Thank you,
Doctor.
Thank you,
Doctor.
Doctor.